Welcome to Chapter 21, Therapeutic Drugs 2, Antidepressants. This is Part 2, or a continuation of our talk on antidepressants. Okay, we're going to talk about um, analysis of antidepressant drugs and also toxicity and postmortem findings to complete our discussion of this chapter. So let's go to the first slide after this title slide here. And there it is. So in an introduction to analysis, enzyme and fluorescent polarization, immunoassays are available for clinical use. And there are commercial immunoassays that are enzyme and fluorescent polarization based that are available. Although these kit assays are useful for certain tricyclic antidepressants, or TCAs, neither is all-inclusive that are available. Positive and negative data must be interpreted in strict accordance with the manufacturer's guidelines using these kits. Extraction and chromatographic techniques dominate the literature on the analysis of antidepressants, at least in recent years. The antidepressants are for the most part organic bases, basic type compounds with moderate pKa's and enough lipophilic character to make them amenable to extraction procedures. Double or back extractions are more often done in forensic specimens. Liquid-liquid extractions have dominated the literature also recently. However, solid phase extraction is becoming commonplace and actually the preferred method for extraction of antidepressant drugs from biological fluids. In general, the extraction of antidepressants can be accomplished by a variety of techniques. The choice of techniques, of course, will depend on the purpose of the assay, the preference of the analyst, and the instrumental technique used for detection and quantification. Gas chromatography, as you can see on this next slide, is a widely used screening and quantifying technique used for antidepressants and biological specimens. No surprise, it's a classic technique used throughout forensic toxicology. The columns that are used in GC are typically fused silica capillary columns with bonded nonpolar to intermediate polarity methyl silicon. The liquid phases that are used are 0 to 50% phenyl. The usual column dimensions areas are about 10 to 30 meters in length. Internal diameter is 0.2 to 0.53 millimeters, and the film thickness is 0.25 to 1.5 microns. Those are just typical characteristics of columns that are used in the GC. Most antidepressants can be detected in routine temperature programmed analyses using the GC. Nothing real special needs to be done. Here's table 2, relative retention time of antidepressants. This is relative to amitriptyline of the common antidepressants on a 5% phenyl methyl silicon column. And you can see the time, relative time, as compared to this one right here, amitriptyline, which has a retention time of 10.25 minutes. So all of these are in relation to that. So you can see what will come out earlier in the column if they were together in a mixture, and then all these down in this part of the table come out later. Okay, let's continue talking a little bit about GC. One does not usually encounter chromatographic difficulties with antidepressant drugs in overdose quantities, good quantity to measure. However, with low concentrations, or in certain chromatographic systems, the secondary amine or hydroxylated metabolites may have asymmetrical peak shapes. This can be overcome and improved by using acyl, fluoroacyl, or silane derivatives. GC mass spec is now commonly used for routine identification and quantification of antidepressants. Another approach that is gaining popularity is chemical ionization MSCI, mass spectrometry. It has become more accessible with the advent of less expensive benchtop chemical ionization instruments. And here is a figure comparing the electron impact, which is shown up here at the top, and chemical ionization spectra of amitriptyline. When multiple drugs are present or the matrix is very difficult, the chemical ionization mass spec in tandem can be very useful in the analysis. Okay, let's move right along. This one again, this one is electron impact. This one is Cl, chemical ionization. Very simple spectra. Okay, another technique that we have to mention is high performance liquid chromatography, HPLC. Is a very attractive technique for the analysis of antidepressants. The polarity of the secondary amines and hydroxy metabolites can be overcome by the use of HPLC. Methods using HPLC have been completely published for all antidepressants. The columns predominantly used in HPLC techniques are C18 or C8 or CN type columns. Of course, C18 is probably the most commonly used. Mobile phases are typically phosphate buffers with or without ion pairing reagents. The variety of chemicals and polarities make the quantification of all antidepressants on one column and one mobile phase difficult. It cannot be done with just one type of column and one mobile phase for all of the various antidepressants because they are a varied group of compounds, as we've seen. As liquid chromatography mass spec matures as an analytical technique, it will grow in prominence in forensic toxicology laboratories. Okay, now let's shift over and talk about toxicity and postmortem findings. For the most part, the newer antidepressants have less inherent toxicity than the older drugs, but many of the new drugs have properties that can lead to toxic or even fatal drug-drug interactions. This is primarily through their effects on hepatic metabolism and then the drug interactions that occur because of that. The TCAs, the tricyclic antidepressants, are among the leading causes of drug-related deaths throughout the world. Amoxapine and maproteline are so similar to TCAs, or tricyclic antidepressants, that they are included in this discussion. The major toxicity associated with overdose of TCAs, tricyclic antidepressants, is anticholinergic effects, central nervous system effects, cardiovascular effects such as flushing, mydriasis, delirium, confusion, lethargy, fever, seizures, tachycardia, coma, cardiac arrhythmia. Hypertension due to anticholinergic effects and hypotension due to alpha-adrenergic blockade can also occur. Seizures and cardiac arrhythmias are the most likely cause of death. Prolongation of the QRS component of the EKG signal interval, the QRS interval, is diagnostic for these drugs. Okay. Here's a table summary of toxicology data in a series of amitriptyline related deaths. Table 3 is actually summarizing a series of 10 fatalities where amitriptyline was thought to be the single cause of death. Several generalizations can be made. First, blood levels in postmortem specimens are much higher than expected from clinical data in comparison to concentrations in specimens taken near or at the time of death. This is due to postmortem redistribution phenomena that has been detected and observed in the case of antidepressants. Drug concentrations are not static after death. They tend to rise, especially for basic drugs with high volumes of distribution. Blood concentrations can rise by a factor of 2 to 8 during the interval from death to specimen collection. So a very significant phenomenon to take into account, postmortem redistribution of tricyclic antidepressants. Due to this postmortem redistribution, the exact dose taken by an individual cannot be estimated by a pharmacokinetic calculation that depends on the concentration measured in postmortem blood, especially if obtained from the central cavity of the body. The analysis of peripheral blood specimens and tissues can provide information to successfully interpret a case, as opposed to blood from the central cavity of the body, due to this postmortem redistribution phenomenon. A liver specimen is most useful complement to blood specimens in TCA-related cases. The concentration of drug and metabolite is much higher in the liver than in the blood. Trazodone appears to be safer in overdose situations than TCA. Symptoms include drowsiness, vomiting, respiratory arrest, seizures, and EKG changes. Trazodone is less susceptible to postmortem redistribution than the tricyclic antidepressants. Symptoms from bupropion overdose include hallucinations, tachycardia, and seizures. It should be taken into consideration that bupropion is unstable in biological specimens. Continuing, let's talk about SSRIs. SSRIs are the most widely prescribed group of antidepressants. They show fewer side effects and are better tolerated than the first generation antidepressants. They are also safer in overdose situations because they do not demonstrate the cardiovascular toxicity associated with TCAs, but they can show serious toxicity if taken with serotonin-enhancing drugs. All SSRIs show similar toxicity. They cause nausea, vomiting, mydriasis, tachycardia, tremors, seizures, and coma when taken in overdose. Serotonin syndrome has been reported when there is a sudden systematic excess of serotonin caused by SSRIs. Of course, we call that serotonin syndrome. It can be caused by ingestion of SSRIs alone, but occurs more often when SSRIs are ingested with other drugs that have a serotonergic enhancing property. Serotonin syndrome is often delayed as much as 12 hours after ingestion. SSRIs also affect the hepatic cytochrome P450 isoenzymes. The most studied is CYP2D6, which shows polymorphism in populations. When a compound inhibits CYP2D6, an extensive metabolizer can become a poor metabolizer. This enzyme catalyzes hydroxylation reactions of antidepressants, antipsychotics, analgesics, and cardiovascular drugs. Therefore, significant drug-drug interactions can occur when the ingestion of SSRIs occurs. And our last slide, vildaxine, the first drug listed here, vildaxine, a third-generation antidepressant, has the most data concerning its toxicity. Overdose symptoms include tachycardia, convulsions, somnolence, and coma. Symptoms reported as a result of nefazodone, the second one listed. The results of overdose include nausea, vomiting, and somnolence. Because this drug inhibits the reuptake of 5-HT, serotonin syndrome can be produced by the co-administration of an MAOI or another serotonin-enhancing drug. Nefazodone is a weak inhibitor of CYP2D6, but a potent inhibitor of CYP3A4. Mirtazapine, this last one here, toxicity includes drowsiness, disorientation, tachycardia, and impaired memory. Thank you very much. That concludes our discussion of antidepressants.